All right, guys, we're going to go ahead and get started with our noon conference today. I want to thank all of our discussants that are going to be here today to participate. We're going to get the presenter of the case is going to be Dr. Chiao. Dr. Brickson, Dr. Sink, and Dr. Lee are going to be our discussants. And like we've said before, if anybody else wants to ever volunteer, just please shoot Danny an email. And whatever site you are at, it doesn't really matter because we do this all obviously on Zoom. So we'd love to have you on. So without further ado, we'll go ahead and get started. So Dr. Chow, can you start us off with chief complaint and HPI and kind of leaving out as much past medical history as you can?
Absolutely. You guys can hear me okay?
Sound good.
Okay. So the chief complaint is fatigue. And her HPI briefly is, this is a 27-year-old female, G2P0. A prior history of a spontaneous abortion, is presenting from an outside hospital for fatigue and in the setting of a recent second spontaneous abortion 4 days ago.
All right, now, Dr. Chow, for all of us that haven't been on OB in at least maybe 1 to 3 years, so G2 is, the G is going to be how many times she was pregnant, and the P is going to be how many times she gave birth, correct?
Yes, so she's been pregnant twice and has miscarried once with one spontaneous abortion, and now she is presenting after her second miscarriage.
Cool, all right. So anything else kind of pertinent in the HPI for you?
So this is an outside hospital transfer. So when they called the doc line, they mentioned that she has a hemoglobin of 4.8 and platelets of 12.
Okay. All right. Anything else kind of in our HPI for you? Like any other like review of systems that are pertinent, negative?
Sure, that's fair. She is not having too much vaginal bleeding when we asked her. She said that when we asked if she had like any fevers and chills, denied that. Otherwise, actually felt quite well except for fatigue. No bruising or bleeding other than her vaginal bleeding. And then she didn't otherwise complain of maybe some mild paresthesias on her face. But that's about it.
Okay. So I'll turn this over to our discussants, and I wanted to see, do you guys have any questions about this HPI? Any other like clarifying details that you guys would want to know about?
So did she have her spontaneous abortion like this last admission or wherever she was transferred from?
So it sounds like from the outside hospital note was that she had presented a few days prior, actually did not know she was pregnant. She was found to be pregnant in the ED, and they initially thought she had a viable pregnancy, and then she presented a little bit afterwards, within probably that same week, with more bleeding. And at that point, the transvaginal ultrasound, as well as her beta HCG, was showing that she was having a failing pregnancy.
Was that initial?
Go ahead.
Was that initial presentation for fatigue?
Yeah, so she was actually otherwise being managed as an outpatient by OB. She's originally from Gillette, Wyoming. And so she was being managed by OB out there. They didn't specifically admit her for her spontaneous abortion. So she came back feeling like having more bleeding, feeling much more fatigued. And so they found on blood work that she had a hemoglobin of 4.8.
I think, Joanne, somebody asked how many weeks was she pregnant?
She was 7 weeks pregnant.
Okay. Any other big questions you guys got from that HPI, past medical history? Or, sorry, HPI and review of systems and kind of our outside hospital course?
Any headaches or like skin rashes or skin changes?
Has some headaches, but denies any rashes or skin changes or bruising.
I gotta ask Nancy, why are you asking that question?
So like skin changes, I would be looking for like petechiae, especially with her platelets of 12. And then headaches, I'm thinking about like a process going on with her platelets, like ITP or something that could be leading to like headaches.
Yeah, and I guess it kind of going with what you were saying, like somebody's got really low platelets, you know, obviously if they're less than 10,000, usually that's when we get concerned about like a spontaneous intracranial bleed, and making sure like she's got some kind of neuro symptoms, but making sure she doesn't have anything that's more concerning for like a intracranial bleed. I think that's great, really great questions to be asking too. And kind of pushing you guys, what are the things that we, you know, as medicine doctors, we obviously don't come across that often, but, you know, if somebody comes in and they were recently pregnant or they are pregnant, what are kind of complications that you think of?
I think potentially DIC as a complication of recent pregnancy, spontaneous abortion. Also think about like other, as Nancy started to get into other causes of potential platelet consumption. Notable DIC, ITP, TTP, those types of hematologic abnormalities. Do we know anything else about the trajectory of her hemoglobin and platelet decline? Like how quickly that's happened?
So like when like they called Dockline for her request of transfer, they said they found her to have a hemoglobin of 4.8, platelets of 12, and they had given her like 2 units of PRBCs as well as 1 of platelets, and she was still at like a platelet of 19 when they rechecked her.
I would also, this is getting more into OB land, which I haven't looked at in a while, but I also think about HELP syndrome and like other like, I know there's some other liver stuff that can be a complication of pregnancy. You know, you could connect the platelets there as well.
Yeah, Claire, that's a really good point. I want you to, what does HELP stand for?
Ooh, I think elevated liver enzymes, maybe the EL. I would say hemolysis and maybe low platelets.
Yeah, no, totally.
In the wrong order.
No, but that's exactly what it stands for. Actually, and the VA is actually making some real, or it looks like it's Graham that's making some really good points about this. He actually makes a good point that usually HELP is, you think it's a little bit later in pregnancy. It's kind of the same with preeclampsia. Both of those are usually at least in the second trimester is when we expect this. And usually, I think it's not mistaken, it's after 20 weeks is when we think about those complications coming. But totally great thing to think about in this patient who is coming in with these symptoms. Okay, I think that's pretty good. Let's just so we can keep going through the case. Joanne, anything else big on the past medical history, surgical, and anything like that?
Not really. She's otherwise like a fairly functional 27-year-old. She has had a prior history of 1 spontaneous abortion before this one, but denies any history of like bleeding or bruising problems or has ever thrown a clot from as far as she knows.
Okay. And then anything social, family, and is she on any meds?
Social history wise, she used to smoke, probably like it was like she quit in 2015, denies any alcohol use. She's from Gillette, Wyoming. This was a unplanned but desired pregnancy. And then family history wise, again, no like miscarriages, bleeding problems, heart disease or stroke, anything autoimmune that she could recall. And she was just recently started on like metronidazole, so Flagyl for like some BD as an outpatient. But that's it for her meds, really.
Okay, you got. I'm gonna turn it over to our discussants, and I kind of want to see. Do you guys have any other big questions that you'll want from kind of our HPI, past medical, social history?
I would add like rheumatologic review of systems as well. which I know can be kind of broad, but like joint pains, we already asked about rashes.
Claire, why do you? That's a good point. I want to press you on that. Why do you want to know about rheumatologic stuff?
Just with like the abnormal platelet, it's pretty, I mean, those are notably low platelets, but the anemia, and then, I mean, I think of antiphospholipid for spontaneous abortions, and with the other thing, it could be lupus.
Yeah. Really good point. I think it's, that's part of the workup for somebody who's got a late term miscarriage. We think about actually, if these people have, we work them up for APLS because that's one of the etiologies of that. I think that's really good questions to ask. Joanne, any big like rheumatologic stuff, like on any arthralgias or?
No, she's negative. She really was just only complaining of like a pretty bad headache and some facial numbness when she came in.
Yeah. So no, and kind of as FYI, when you're getting a good room history and you're trying to think about all the symptoms of lupus, like the things you do, asking like what you guys asked about, rashes, arthralgias, any eye pain, any mouth ulcers, hair loss, any kind of pleuritic chest pain, something to make you think about kind of the complications of lupus. You just kind of go through that list of things that you on your review of systems to see if they have any of those symptoms. So why don't we do this? Let's from our discussants, and we will let's make a differential diagnosis for her. Why don't we put like 3 to 4 things on here, and then I see we have one in the chat right now, like of another part of the differential, but why don't we hear from the discussants, and then if anybody else has anything else they want to add to the differential, you guys can put it in the chat right now.
So I feel like just with her recent pregnancy, we have to put like DIC on there, like given her thrombocytopenia.
Yeah, I like that. I think that's really good. Totally. That'd be something you don't want to miss in this patient for sure. Eric, Claire, what do you guys think?
I mean, broadly with low platelets and with the anemia, I kind of think about like decreased production, like sequestration, consumption, or like, I guess bleeding, but that's less so for the platelets. I would probably put on there some sort of like bone marrow process that would be leading to decreased production. So I guess, that would be some type of heme malignancy.
Yeah, really good. I think that's totally a great thing to think about. So you're saying decreased bone marrow production, you're kind of linking that with the hemoglobin and platelet level?
Yeah.
Yeah. And so what can you check check at least for red blood cells to make sure there is to check to see how the production is for the hemoglobin?
Get a retic count.
Reticulocytes.
Yeah, totally. Honestly, I use it like as depending on the context of the patient. I think it's reasonable if somebody has low platelets and they have anemia, I think using that in the context of like what their overall bone marrow production is totally reasonable, especially when you're working somebody up acutely. So cool. And then Eric, anything you want to add?
I think we can keep antiphospholipid on there, like some other manifestation of rheumatologic disease, like antiphospholipid causing some sort of consumptive coagulopathy.
Yeah, perfect. Sounds great. I think that sounds like a great thing to keep on. So why don't we'll put that on as well. And then one of the things that Graham mentioned is concern about possibly retained products of conception. So I think it's reasonable. I think Graham is at the VA, so he's not going to have great microphone. But thinking about that, usually these people we're going to be worried about them actually having something like endometritis or chorioamnionitis, whatever the heck it is, but something where you actually have like diffuse abdominal pain, they look septic appearing, but I think kind of linking that in with possible DIC is totally reasonable too. So why don't let's go ahead and let's get her vitals and then her physical exam, and we'll see how that changes our management.
Sure. Her initial vitals are blood pressure is 128/70, pulse is 79. Her temperature is 37.2. She's sitting on room air 94%, breathing 18 times a minute. Her exam, she's not really in any extreme or acute distress. She has, the exam is, she's moving all her extremities on her own, overall fairly non-focal. Her cardiovascular exam, she has like a systolic flow murmur present, otherwise regular rate and rhythm. Clear lungs to auscultation bilaterally, benign abdomen, and no edema in her extremities.
Okay. Anything else you guys want to know about her physical exam?
Sorry if you mentioned this, but skin exam, like bruising, petechiae, jaundice.
Good.
There's no petechial rash when technically so she was an overnight admit, but when we saw her that morning, she didn't have like a petechial rash or any profound bruising or anything that we noticed.
Good. Yeah, totally. That's a great question. Her platelets are that low. I'd be worried about her having some kind of or it would be at least one of the physical exam findings, thinking of a thrombocytopenia with these like diffuse petechiae. Okay, well, let's go ahead. So we're going to get these basic labs of the CBC, BMP, and CBC. We already know a little bit about it. Any other, once you guys, y'all have a max of 3 other labs that you can get. What labs kind of prioritizing are you going to order for this patient outside of a CBC and BMP?
I'd like to get a peripheral smear.
Good. Why do you want to get peripheral smear, Nancy?
So if she has like schistocytes on there, it would be more concerning for like a hemolytic process. Yeah.
Yeah, totally. When you see schistocytes and you think about like you think of a hemolytic process, any like in particular you get more worried about?
Like from our differential?
Yeah.
Like DIC would show that. Yeah, that's the one that comes to mind.
Right. And anything else from you guys, Eric and Claire? What other labs would you guys want to order?
I would probably prioritize DIC labs just because that's like kind of before work going on with the workup. That's something you wouldn't want to miss in terms of management.
And what DSC labs are you talking about?
Like I would want haptoglobin, fibrinogen, INR. I'd probably want an LDH.
Perfect. And then I'll count that as just one lab because I think that's fair. That's a whole collection of labs. But Eric, anything else that you would want on this patient right now?
Yeah, just to kind of evaluate her. Starting off the rheumatologic evaluation, I'd get an ESR CRP.
Okay. Yeah. Now you guys kind of mentioned about when we're talking about a decrease in the lines in our blood counts, and you're wondering if this is going to be from a destruction or a production thing, is there anything you would want to get in addition to all this to see if it's a production versus a just destruction?
The retic count, is that what you're?
Yeah. So I'd probably throw in I think getting a retic count on her is a good idea too. So.
And then do we already have LFTs? I'd like to see what her billy is.
Yeah. And why do you want to see her billy, Nancy?
So if it's destructive, then her billy can be elevated.
Is there one billy in particular that's more elevated usually?
I'm actually not sure.
It's usually
the indirect billy.
Yeah. Usually it's their indirect billy is going to be the elevated one. If you have like an intravascular hemolysis process going on. Cool. Why don't we go ahead and let's get some of these labs. So, Joanne, do you mind? So CBC, BMP, and LFTs are, and then the rest of those.
Okay. Sure. CBC, she has a white count of 9.2, And then after her resuscitation, so these are her admission labs when she came to the U. Her hemoglobin is 6.8, with an MCV of 94, and then her platelets are 12.
Okay.
And her
I'm
B,
gonna write this out for everybody. Give me 1 second.
okay, go ahead. Sorry.
Oh shoot. Here we gotta. Oh damn, isn't that right? Never mind. I don't think the whiteboard's working. Huh?
Okay.
Nope. All right. Cool. All right. You want to share? Okay. All right. Sorry. Go ahead, Joanne.
Metabolic panel, her sodium's 141, potassium 3.1, chloride 107, bicarb 25. Her BUN is 17. Creatinine's 1.16. Calcium's 8. Mag is 2. Her LFTs, her alk phos is 43, ALT is 23, AST is 22. Total Billy is 3.4. Indirect is 2.9. Total protein is 6.2, and her albumin is 3.7.
Okay. And then what about those DIC labs and DIC labs that we had gotten?
Sure. Her PT-INR is her INR is 1.2. Her fibrinogen is 320. Her APTT is 29.6, which is normal. Along with the hemolysis labs, her haptoglobin is less than 30. Her LDH is 1,153. And then the smear that Nancy wanted had +1 schistocytes on the smear.
And then what was her retic count?
Her retic count, let me find it, hold on. Let's see. Reticulocyte was 16. The absolute was 0.35.
Yeah, I think 16 is good. So 16 is like the percentage of count it is. There's actually a good, it's your retic index. If you go into MedCalc, it's a good way to like look to see if the reticulocyte count is actually an adequate amount for their level of anemia. And so usually if you plug, I can just tell you from that number, 16% is going to be plenty high. So looks like she probably is reticking enough for her, she's actually has a large enough retic count for that level of anemia. So, okay, so I'm going to turn this over to the discussants. I want to hear what you guys think now. What are you guys thinking about for your differential, and what do you guys want to order now? What would be your next lab that you would order at this moment if you get one lab?
I don't know if this would be my one lab, but we also don't have a D-dimer just in terms of DIC labs.
Yeah, good. That's a good point. Joanne, what was her D-dimer?
Sorry, I did not tell you guys that one. My apologies. 3930 was her D-dimer.
Now, what are you guys thinking? What if you had to choose kind of in your next step, what would be the next lab that you would order?
Like an Adams 13.
No, that's a good. And what are you thinking about with that, Nancy?
So maybe like TTP. She's obviously hemolyzing, her platelets are low. Yeah.
Yeah, and so the Adam TS13 is it'll take probably about 3 days for it to come back. So I guess so I think you're mentioning, what do you think is the etiology for her low hemoglobin right now?
So I think she has a hemolytic process.
Perfect. Yeah, nice. And so what is kind of part of if you think somebody has a hemolytic anemia, what is kind of a lab that you want to see if there is, if you want to check to see if this is an autoimmune process causing the
We
hemolytic?
could also get like a Coombs test.
Yeah, nice. And that, and what, yeah, so I think that's perfect. Yeah. So, why don't we see what was her Coombs test, by the way, Joanne?
Negative.
Yeah. So does that, for you guys, does that point you one way or the other? Or what are you guys thinking now that she's got negative Coombs test?
That's probably not it's probably not antibody mediated then.
Yeah, I agree with that. So if you had to kind of revise your differential diagnosis now before kind of ordering any other labs or anything, what would you what would be on your differential diagnosis? Do you guys want to keep it just the same as it is right now, or do you guys want to change, add, remove?
So I don't think it's DIC, just because her fibrinogen is pretty high for that. And then I don't think it's a production issue because her ticks are elevated. It's obviously more like a lysis issue. So I don't think number 2. I think the other 3 are still fair game.
Okay. Now, do you want to add anything on there, or do you want to keep it just those 3 right now? And what would be, I guess, like what would be at the top of your current list?
I think I would think about like TTP-HUS.
Yeah, I think that's great. And I guess like thinking about TTP-HUS, why is that kind of one of the things you need to, if you're going to think about it, why do you need to kind of think about, I guess I'm trying to see how to say this. Why is it important to identify TTP early? And this is kind of a what am I thinking question, but I think the big thing to know is that TTP is one of these diseases that we need to treat urgently. And so it's not one that you can kind of necessarily wait for the ADAM TS13 to come back to treat it. It's one of these, if you suspect TTP enough, you should be treating it for TTP. So I want to see from you guys, do you guys, so you ordered sounds like we ordered the ADAM TS13 that's just pending right now. Do you guys want any other labs, any other imaging?
For the sake of completeness, probably add on the Shiga toxin. Doesn't sound like she's having diarrhea.
A UA, I think.
Yeah. So this is actually a really interesting point. So Eric, I'm going to push you a little bit on this one. So you said you're thinking about the Shiga toxin.
Yeah.
And you're saying that because you're worried about some kind of hemolytic process or TMA, a thrombotic microangiopathy,
Right.
includes TTP and HUS, that's causing her to have this low platelets and anemia. What's the one thing in her labs that kind of point away from that? And you can totally call a lifeline if you need.
She has normal, like relatively normal renal function.
Yeah, totally. Yeah, that's the big thing. And you actually made a really good point. She's a 27-year-old female. Her baseline creatinine could be like 0.5, and so this could be an AKI for her.
Yeah.
But yeah, usually if we'll just say for completeness sake, her creatinine is her baseline is 1.1 just for baseline etiology.
I would expect TTP or HUS to have a much more significant impact on renal function if that was happening.
Yeah, that's actually this is a good teaching point. So it is actually, we get taught the mnemonic for TTP, the fat RN, which is, do you guys know what all that stands for TTP?
I do not.
So I think F is fever, A is anemia, T is thrombocytopenia, R is renal, and then N is like neuro issues.
Yeah, exactly. The one caveat to this is that the renal is actually not as common in TTP. It's less. It is something that can happen, but it happens much less frequently than it does in, say, HUS. Okay, so why don't we? Do you guys have any other like labs, imaging that you guys would want to get at this point? Or why don't we? I'm gonna kind of press you guys a little bit more. Why don't you guys tell me what would you do with, you have these labs and her HPI. What do you guys want to do for this patient right now? Do you guys want to run more labs, get some imaging? Or do you want to treat her?
I don't know if this is somewhat cheating, but I think like if we have a high enough suspicion for TTP, I would be talking to hemonc, and specifically would be, asking if there's sort of like urgent treatment. I think it might be like plasmapheresis or something, or just like what we could sort of do right away if we have a high concern for this.
Yeah, totally. That is exactly right. If you guys have, if you have high enough concern for TTP, you should totally be calling hemonc at this moment. So, so you talk to hemonc, they say that they have a decently high suspicion for TTP. So what are you going to do for this patient what are you going to do for this patient? They say there's pretty high suspicion for TTP.
If after discussing with hemonc they think high enough suspicion that we should start treating, she's going to need a line. So I would line her up and start TTP or start plasmapheresis.
Yeah, and so this is so actually, and this is just a for these patients when that TTP, are you going to do a plasmapheresis or are you going to do a plasma exchange? And can you guys tell me what the difference between the two is, if anybody's comfortable with
that? Is plasmapheresis actually like filtering out something from the blood, whereas plasma exchange is what it sounds like. It's like replacing the patient's plasma with fresh plasma.
Yeah, exactly. So you're literally putting back in those products that are being removed from the patient, or that are going to be deficient in this patient. So giving them the Atom TS13 if they're lacking in these patients with TTP. So Joanne, so you get this patient in the morning. Sounds like Eric's saying he's going to line up this patient. What ended up happening the next morning when you guys were with her?
Yeah, so night shift was worried enough that she potentially had TTP, so they did call hemonc, and then they felt that hemonc gave Rex and was waiting for like the negative Coombs test to kind of sort of push him more towards TTP, and then said if that was high enough suspicion to actually call room to get a bunch of her rheumatologic labs before she gets plexed. And then night shift was kind enough to place some Herker in this lady. And renal was already called. And so she was consented for plex the morning of picking her up on day shift.
And so did she have, when you were with her that next day, did she have any complications or issues that kind of arose?
Yeah. So her thing is, while they were getting her all settled in for all the presumed TTP, She actually first stroke alerted on the evening that she was admitted. So overnight, she actually got one stroke alert called already for like facial numbness and mild dysarthria. So stroke had already seen her, and they were recommending brain imaging. But all of her symptoms resolved them by the time I saw her that morning.
And what did you guys? So they got brain imaging. What did the brain imaging show?
So she got an MRI, and her MRI of her brain showed that she had multiple acute infarcts throughout her brain, like the frontal lobe, parietal lobe. That was just consistent for acute strokes.
What do you guys think about that? All our discussants. You're taking care of this patient. You got 27-year-old woman she has what we're concerned about is TTP. She's got facial numbness. You get an MRI, and you see a bunch of strokes on her MRI. But what do you I guess, do you think this is part of? Are you concerned that something else is going on, or do you think this is from TTP?
I think anytime you have like multiple distributions of stroke, you have to think about like an embolic process.
Yeah, I totally agree. I think that's a great point, Nancy. And I think definitely making sure she doesn't have an embolic process going on would be, you have to rule that out before associating it with anything else. But I think going along with the TTP definition, like this is actually probably this could be like a neuro complication from her TTP. Joanne, what did neuro say about all these acute strokes?
So because of her thrombocytopenia, they can't give her TPA because of her risk of bleeding. That was the concern. Thankfully, she self-resolves on her own in terms of her symptoms, and that this is most likely consistent with her TTP.
Okay.
Yeah, we did do an echo with bubble, and that was negative.
Good, cool. So tell me, what did her Adam TS13? What level did that come back as?
So it came back yesterday, and it was less than 5.
So what did you guys end up diagnosing her with?
We diagnosed her with TTP. She's now on day 4 out of planned 5 of Plex. And in that same vein of treatment, she's also been on 125 Q6 of Salimedrol.
Nice. So I guess the next question is I don't know if Hemonk or has talked about this, but what did they say? How did she get, what is their thought on why she got TTP?
I don't think we've actually talked about that yet, specifically with Hemonk.
So there's, and I will tell you, I actually looked this up about TTP, and it's actually pretty interesting because usually there's 2 things you need to think about TTP. There's a hereditary form, or there's an autoimmune form an autoimmune form where there's actually an antibody directed towards Adam TS13. And so I think it kind of made sense with you guys with her history of spontaneous abortions. Does she have a history of APLS and lupus? And was this the etiology for her? Like, does she have an autoimmune cause of an antibody that's directed toward Adam TS13? What I actually kind of, Cassandra's put a great point on here. I'll get to that in a second. The other thing is apparently hereditary TTP is more common to present in kids, but it can present in adulthood. And the times it does present is any time that you have elevations in your level of von Willebrand factor, which totally makes sense because Adam TS13, you guys remember, like it cuts the von Willebrand factor. And so if you have when it's not cut, you're going to have hypercoagulable state. And so whenever you have excessive levels of von Willebrand factor, that can actually cause you to have a TTP flare. And so what they actually said is that they talked about, kids who have enuresis, they get desmopressin at night to help them not wet the bed. They can have a TTP flare. but it can also happen in pregnancy. So pregnant women have an elevation in their levels of von Willebrand factor, and that can be like the initial presentation of TTP, interestingly. And Cassandra, Cassandra put a great thing out here. So yeah, there are certain drugs that can actually cause you to have a drug-induced TTP as well that you need to make sure that she wasn't taking. Cassandra, do you by chance know what drugs those are? Because I saw them, she was just on Flagyl was the recent one, but I saw that Hemonc didn't really comment on that's not a typical drug that we think about causing TTP. Yeah. So yeah, that's fair. Up to date's probably where you're going to go if you're worried about finding the drugs that cause it. So, Joanne, anything else big that you think was kind of pertinent to this patient's case that'd be really good learning for us? We got like 15 minutes.
I think I mentioned earlier that like the Coombs negative part was super helpful for the TTP suspicion. And then this is credit to like Emily Simons, because in her note, she actually wrote like, if you're going to plex the lady because you think she has TTP, you should get the room labs first to not confound your laboratory workup. So that was actually, it's more of a logistical workup kind of thing, but I actually felt like that was one of the bigger learning points in her workup process.
Yeah, that's a really good point. And actually, I have of that same note, patients that I've actually given a patient an IVIG before, and they had a false positive antibody. And so that's also another thing to kind of keep in mind. If you're going to look for certain serologies, you're going to need to ideally draw those serologies before you either give these people IVIG or if you're going to plex or plasmapheresis them. I think that's a really good point. In discussants, I just want to see, do you guys have any big learning points that you got from here, or anything that you guys would want to add?
Definitely the need to treat early if someone has a TTP or another MAHA in order to prevent the severe complications of the disease. So recognizing those recognizing early and calling the heme fellow as early as you can to start the plex or plasma exchange.
Yeah, no, totally. That's a good takeaway, because this is an urgent thing, because these people can get really sick really quick. I think one of the things that we didn't mention is that Joanne, when she talked about that she got a union of platelets and her platelets just went up like a smidge. You know, when you see that, that's another time you should think about a consumptive process with those platelets, whether it be ITP or another TMA or DIC. It's really good to keep that in the back of your mind. Okay, perfect. Well, we'll go ahead and end conference early. Thank you so much to all our discussants. Thank you so much, Joanne. That was a fantastic case. Really got some, I think that might have been like my first TTP case to ever see here. So I really was pumped to talk about it. So thank you so much. And thank you, Nancy, Eric, and Claire for participating.